I'm David Kerr, Professor of Cancer Medicine from the University of Oxford. One of my abiding interests has been how we use clinical guidelines to level up treatment nationally and internationally. And certainly when I advise governments in terms of national cancer planning, we put guidelines often at the heart of any of the advice that we tend to give. Picked up in a really interesting study that has been published recently in Lancet Oncology. This is a large collaborative study looking at chemotherapy uptake and usage across a period of 5 years. And it was a combined study coming from Norway, from the United Kingdom, from Canada and Australia. They looked across 8 different tumour types, gastrointestinal cancer, lung and ovarian. And the interjurisdictional differences in chemotherapy uptake were amazingly large. For example, with ovarian cancer, they range from around 40% to 85%, with a median in the middle of around 65%. And those sorts of figures were repeated across the wide range of tumours that were looked at. So that was just chemotherapy usage. Again, very significant variations in time to starting chemotherapy. And another thing that popped up, perhaps it didn't surprise us, that elderly patients, those of 80 and above, had chemotherapy 20 times less frequently than those who were younger. So what underpins these differences? And when I think about national cancer planning, for me, it's about seeing what we can do to bring up to some common level, some common standard, the types of drugs that we use, the chemotherapy regimes, the indications, the staging, all the things that you'd expect in guidelines. If we look at the national guidelines across these different countries, they're not very different, nor would you expect them to be. If we look at the global domination of NCCN, our own guidelines from ESMO, from ASCO, subtle national variations of these, they're all very much of a muchness, and yet we see these big variations. Is it all political? Is it funding? Is it different types of healthcare systems? Is it access to certain types of drugs? Is it using, institutions like NICE that health technology assessments that cause variation in access and timing and so on? Each or all of these are potentially contributory. So we need to understand better. We need to find out more. But for somebody like me naively to think that once we have projected, once we have made a national cancer plan, once there's set our guidelines, that these will be taken up and applied uniformly, is clearly wrong. I guess it's a disconnected hierarchy you sometimes get from people like myself who are involved in national plans, international plans and so on, and assuming that the good advice will filter down and will be taken up. Fascinating piece of work. It involved around 800,000 patients between 2012 and 2017. Very well worked up, very strong cancer registries and databases, and some frankly profoundly troubling data, because if we believe that chemotherapy is a useful tool in the treatment of those tumour types, then such a degree of variation in its uptake and usage, I think, is a source of trouble, a source of puzzlement, certainly to me. So watch this space. I'm sure these authors will be approaching and thinking more deeply as to what the underpinning causes are. But for the time being, I'd be really interested in your thoughts. Perhaps you're not surprised at all. Perhaps it's just real politic and real time. But I'd be interested in your thoughts. For the time being, Medscapers, over and out. Thanks for listening as always.